Section 4, the finale, hypertensive crises. And I said crises, plural, because there are actually two distinct clinical scenarios here. And conflating them is a mistake that leads to either undertreating someone with actual end organ damage or overtreating someone who just needs their oral medications adjusted and a follow up appointment. Hypertensive emergency, organs are being damaged right now. Hypertensive urgency, blood pressure is sky high, but the patient is actually fine. Completely different management, completely different urgency. And the number one thing I want you to walk away from this section knowing is how to tell them apart. Hypertensive emergency. The definition: severely elevated blood pressure, usually above 180 over 120, with evidence of new or worsening end organ damage. The blood pressure the blood pressure number alone does not make it an emergency. The organ damage does. What counts as organ damage? Hypertensive encephalopathy, intracranial hemorrhage, acute ischemic stroke, acute MI or unstable angina, acute left ventricular failure with pulmonary edema, aortic dissection, eclampsia, retinopathy, or papilledema, which is why you do a fundoscopic exam, but also there's decreased urine output or acute renal failure that counts for end organ damage. The actual blood pressure value matters less than the rate of rise and the evidence of organ involvement. A patient with chronic hypertension who runs 180 might tolerate it a little better than a previously normotensive patient at 160. So context is everything here. Hypertensive urgency, severely elevated blood pressure in an otherwise stable patient with no acute organ damage. No encephalopathy, no chest pain, no new visual changes, normal renal function, normal neurological exam. These patients do not need to be in the ED. They do not need IV medications. There is no proven benefit to rapidly reducing blood pressure in urgency. What they need is their chronic medications reinstated, dose adjusted, or compliance addressed, and a follow-up appointment within 1 to 3 days. The number of patients admitted to the hospital for hypertensive urgency who receive IV labetalol or nicardipine is a lot, and most of them did not need it to begin with. For hypertensive urgencies, the standard approach is to blood pressure reduction. I'll repeat that one more time. For hypertensive emergencies, the standard approach to blood pressure reduction is controlled and staged. You lower the mean arterial pressure by no more than 25% in the first hour. Then you bring the systolic to 160 and diastolic to 100 to 110 over the next 2 to 6 hours. Then normalize over the next 24 to 48 hours. This is controlled demolition, not a free fall. So why not just slam it down to normal immediately? Because rapid blood pressure reduction causes ischemia. The brain, heart, and kidneys rely on autoregulation to maintain perfusion at high pressures. So when you drop the pressure too fast, autoregulation cannot catch up, and you cause the very ischemia that you were trying to prevent in the first place. But every rule has its exceptions, and these four are critical. So in patients presenting with acute ischemic stroke, do not lower the blood pressure unless it's above 120 over, unless it's above 220 over 120 or above 185 over 110 if the patient is a thrombolysis candidate. The ischemia penumbra, so that's the tissue around the stroke that's still alive, depends on elevated pressure for perfusion. You lower the pressure and you extend the stroke. Preeclampsia and eclampsia patients, Here you go lower and faster. Target systolic BP below 140 within the first hour. IV labetalol is preferred. ACE inhibitors and ARBs are contraindicated in pregnancy, and nitroprusside, avoid it because of fetal cyanide toxicity risk. Your patient with aortic dissection. This is where you go aggressively fast. Systolic BP below 120 and a heart rate below 60 within the hour. Beta blockers first to reduce shear forces on the aortic wall, then your vasodilator if needed for additional BP reduction. If you give the vasodilator first without the beta blocker, the reflex tachycardia increases shear force and you make the dissection worse. Then you have your pheochromocytoma. Alpha blocker first, phentolamine. Then you can add beta blocker once alpha blockade is established. If you give a beta blocker first in a pheo crisis, you block peripheral vasodilation and get unopposed alpha stimulation. Massive vasoconstriction here, and the blood pressure goes through the roof. So 6 IV antihypertensives, know their mechanisms, their indications, and their contraindications. Nicardipine, dihydropyridine calcium channel blocker, 5 to 15 milligrams per hour, titrate every 15 minutes, consistent and titratable. One of the most versatile options in the toolbox. Studies have shown it achieves blood pressure targets more reliably than labetalol in several head-to-head comparisons. There's no dose adjustments needed for age. The main contraindication here is advanced aortic stenosis. Labetalol, your alpha and beta blocker, which is actually pharmacologically elegant for hypertension because you're blocking both the cardiac and vascular components simultaneously. 20 to 80 milligrams every 15 minutes or an infusion. Great for hyperadrenergic states, cocaine, alcohol withdrawal, autonomic crisis, also used in aortic dissection in combination. But absolute no in reactive airway disease, decompensated heart failure, bradycardia, or heart block. Esmolol, here you have your selective beta 1 blocker with an ultra short half-life of 10 to 30 minutes. This is your drug when you want beta blockade that you can turn off quickly. So in situations where you have aortic dissection or perioperative hypertension, ACS, same contraindications as labetalol, no in decompensated heart failure, and no in reactive airway disease. Nitroprusside, arterial and venous vasodilator, powerful and fast, but cyanide toxicity is real, especially with prolonged infusions or high doses in patients with renal or hepatic function failure. Avoid inactive ischemia, coronary steal syndrome, and needs an arterial line, and reserve for situations where you really need the power and you have the monitoring to go with it. Phenoldiprem, dopamine 1 receptor agonist. It's unique because it has renal protective effects. It increases renal blood flow, which is useful in the setting of ACS with kidney disease or contrast nephropathy risk. It's contraindicated in glaucoma because it increases intraocular pressure. Clofidipine, your ultra short-acting dihydropyridine CCB. Onset 2 to 4 minutes. Duration 5 to 15 minutes. It's very titratable, great for perioperative hypertension. Watch for rebound hypertension if you stop it abruptly and haven't transitioned to oral therapy. It's contraindicated in soy or egg allergy. It's the lipid vehicle. Okay, this slide is about matching the drug to the underlying crisis. because it's not just about lowering blood pressure, it's about protecting the organ that's at risk. Aortic dissection, labetalol plus esmolol, beta blocker goes first, always. Reduce heart rate and contractility to decrease aortic wall shear force. Then layer in a vasodilator like nicardipine or nitroprusside if you need more BP reduction. Acute coronary syndrome, esmolol or nitroglycerin is preferred. Labetalol and nicardipine are reasonable alternatives. Avoid nitroprusside in active ischemia because of coronary steal. Acute pulmonary edema, nitroglycerin, clevidipine, or nitroprusside for the combination of vasodilation and decongestion. Beta blockers are contraindicated in acute decompensated heart failure. Nitroglycerin is especially preferred when it comes to concurrent ischemia. Eclampsia, labetalol preferred, nicardipine or hydralazine are alternatives. No ACE inhibitors, no ARBs. These are teratogenic. No nitroprusside because of fetal cyanide toxicity. Intracranial hemorrhage. Now this one is tricky. You lower blood pressure, but carefully. Immediate reduction below 140 is not beneficial and may be harmful according to recent data. So use IV continuous infusion agents such as nicardipine and clevidipine. These are well studied here. Avoid hydralazine, nitroglycerin, and nitroprusside because they can increase intracranial pressure. Cocaine or sympathomimetic crisis, benzodiazepines first to address the adrenic surge, then phentolamine or nicardipine or nitroprusside for blood pressure. And here's the big trap. Beta blockers alone are dangerous because you get unopposed alpha stimulation. Same physiology as FeO. So don't give an isolated beta blocker to a patient who is experiencing a cocaine overdose. So final 5 points to close out this series. 1, emergency means organ damage is happening right now. Urgency means the blood pressure is high and the patient is fine. The treatment is completely different and you should not manage these the same way. 2, the standard reduction target is no more than 25% mean arterial pressure drop in the first hour. Staged, controlled, deliberate. Rapid overcorrection can cause ischemia. 3, know your exceptions. Stroke, don't lower unless above 120, 220 over 120. Dissection, systolic BP below 120 within 1 hour, beta blocker first. Preeclampsia, systolic BP below 140 within the hour, labetalol preferred. 4, nicardipine is your workhorse for most emergencies. Labetalol shines in hyperandrogenergic states. And nitroprusside is powerful but needs careful monitoring and is contraindicated in renal failure and active ischemia. Phenoldiazepam if you're worried about the kidneys. 5, hypertensive urgency does not need IV medications, does not need an ED visit, and does not need hospitalization. Resume or adjust oral therapy and follow up in 1 to 3 days. That's it. And that is the complete Acute Care and Cardiology series. 4 sections: ACS, ADHF, arrhythmias, and hypertensive crisis. Everything you need to know for clinical practice, board exams, and understanding the pharmacist's roles in some of the highest stakes moments in medicine. If you learned something today, please hit subscribe. Drop a comment with what section you want me to break down next. Share this with a colleague who's studying for the boards, and I will see you in the next note.